A very good evening to all. On behalf of IAP technical team, I, Dr. Uttara Mohan, welcome you to this webinar, Advancement in the Clinical Practice and Ethics in Physical Therapy Field in India. We are streaming live on IAP India YouTube channel. Please subscribe to this channel to get regular updates during our webinars. You can also follow our updates and notifications on the IAP Facebook page. Today's moderator is Dr. Krupa Time. I request Dr. Krupa to please take over.
Thank you, Uttara ma'am, for giving this opportunity. First of all, I welcome you all on the behalf of IAP and IAPWC, Rajkot district from Gujarat. I'm very thankful to the all IAP central team, Dr. Ruchi Vashne ma'am, Dr. Pooja Kamble ma'am, Zone Head IAPWC, Bhavna ma'am, Gujarat State Head IAPWC, and Devangi ma'am, Gujarat State Sub-Coordinator IAPWC, as well as my coordinator of Rajkot District, Dr. Vaibhavi ma'am. Myself, Dr. Krupata, I am working as an assistant professor at School of Physiotherapy, RP University, as well as I am serving as a sub-coordinator of Rajkot District. Our today's topic of webinar is Advancement in the Clinical Practice and Ethics in Physical Therapy Field in India. Our today's speaker is Dr. Varsha Jalandhara ma'am. I would like to give brief introduction about ma'am. Ma'am is working as pediatric therapist and working as a director at Vatsalya Pediatric Rehab Center in Junagadh, Gujarat. She is having completed her DPT degree from New York, USA. Teaching experience of DPT and PTS students for more than 9 years. She is license holder of states of North Carolina, Virginia, and New York, USA. She has served in many different countries like Bhutan and US and all. So I would like to request Varsha ma'am, please enlighten us with your knowledge regarding the advancement in our physical therapy. Over to Varsha ma'am. Thank you.
Good afternoon, guys. Thank you very much for giving me this opportunity to share my experiences with you. It really feels odd not wearing mask and talking because we are so used to of mask for like last few months, and I hope we all are doing good and staying safe. Last month when Krupa asked me to I think she has given enough introduction about me, so I'm not going to take any extra time mentioning about myself. I worked as a PT in US for 9 years, since 2011 to 2019. And then due to family priorities, we moved back to India in Saurashtra, Junagadh. So when she asked me if I can share some of my experiences, some of my knowledge regarding how practice differences in the States and in India, and I thought it's a good idea. And I don't want to differentiate whether US is better and India is any behind. Rather, I would like to take like what are the points, what are the topics, what are the criteria that we can check in our practice. I'm hoping that everybody is hearing me good. And please let me know if there are any difficulty in seeing my screen or hearing my voice. So we will just go through some of the points or some of the topics that I would think if we can make a little bit of changes, we can definitely advance our ethics and clinical practice standards in India. Now, I have left, when I graduated in 2010 and I left India and then directly landed in 2019. So in 9 years, it has changed a lot. But I do not have much of the idea that how much it has changed. So you might be seeing that some of the advancement is already there, but I have still taken into the point. So if we all are practicing those, that's wonderful. And if we are not, let's just try to enroll in our practice from today. Anytime, it's an open platform to share ideas and any question, concern, ideas, your experiences, just an open platform. So just go ahead and type a message or just come up with anything you have to share, okay, anytime in between. So my topic is advancement in clinical guidelines and ethics in the field of physical therapy in India. And I'm going to cover, these are the objectives. So definition of ethics, clinical competency, evidence-based practice, which understanding clinical practice guidelines, uniformity in the evaluation assessment format, and treatment protocols across cities and states. Now this varies a lot in cities as well.
Dr. Varsha,
Yes, ma'am.
sorry to interrupt. Can you share your screen again?
Okay.
Turn on the screen share once.
How about now?
Yes, it's visible. Please put it on full screen mode.
I think if
Like,
if I enlarge the screen, then it will not. It's good.
yes, yes, now it's clear.
Objective outcome measures, objective scales and their importance, documentation, electrotherapy and their misconception, patient education, and malpractice. Now, ethics has a lot of theory to enroll, but I will try to just keep some of the practical points which we can implement. Um, so the definition of ethics, a branch of philosophy which defines what is right and wrong and what should be ought to be done. Now, Dunstan defines ethics as an obligation of moral nature which governs the practice of medicine. Clinical ethics refer to the application of the science and understanding of morality in the field of medicine and health sciences. The goal of clinical ethics is to improve quality of patient care. So the main baseline for ethics is to improve our patients' quality of care. Ethics is central to clinical medicine for two reasons. Provider and patient must choose what ought to be done among too many choices for a patient's particular case situation. Now, for example, if patient comes with the back pain, so back pain is like a very vague diagnosis. It has around so many of 15 to 20 differential diagnoses. So what is the right diagnosis among all the differential diagnoses? So choosing the right diagnosis and choosing the right treatment. So that is what patient provider must choose what ought to be done among too many choices for a particular case situation. And the second part is concept of good clinical medicine implies that both technical and ethical consideration are taken into account. That means clinical competency. So there was one thing when I enrolled in physical therapy, or when I graduated, and then not many of like 95% of, or I wouldn't say 95, but 90% of our students, me, I wasn't happy getting into the field of physical therapy, right? Not so when we are not happy, when we are not doing something which we like whatever we like to do, where we are not getting into the field, we are not going to be clinically competent. We have to like what we are into. So when I was in US, when I was teaching DPT students and PT assistants, I noticed one thing, that they were very passionate about their field. They were very passionate to gain the knowledge. They were very proud of being a physical therapist. Maybe because they had to pay $100,000 to get admission into the PT school. Maybe after even graduating, they had to pay the loan for years. And it's the same thing here I see in many right now. Like many of the therapists, they are not happy being a therapist. And when we are not happy being what we are, we cannot be competent enough to get the best out of us, to provide the best treatment. Now, this is my general observation. I could be wrong as well, but this is what I have seen in my experiences. So, what I'm insisting, just be passionate about what you are doing. Then and then you can be clinically competent, and then you can get best quality of care. You can provide best quality of care to the patient, and then that patient will be happy, and then the patient will see you that this field is very effective. Many of the therapists also, when I was in Bhutan, many of the therapists will come and tell me, ma'am, patients, they don't look at us as a doctor. And I was very surprised, like, why does that matter as much? When we see that these people are not looking us as a doctor, we consider ourselves inferior from the first point, that we ought to look, we ought from the people that they should be considering us as a doctor. I mean, I'm happy what I have, because when my pediatric ortho surgeon calls me and he will ask me that, ma'am, this is your child here, and now do you suggest me to give him injection, or do you suggest me to do plaster of Paris casting for a few weeks? So I feel proud. I did not want to be a doctor. I am proud what I have, because they know that whatever my job is it cannot be replaced by other people. So just be what you are at your best. So that's first thing we need to take out of our mind, that do not compare yourself with other doctors. Do not feel inferior. And when you are in the field, gain knowledge from the day one, like your field, and when you will like it, then you will learn it. Then you will seek for the knowledge. Okay, so the first role of ethics or CPG's clinical guideline practices, we have to have clinical competency. So I think that was very important, because that's what I have seen around here, that we must start liking our field, and then we create our own individuality. We do not need to compare with other people. And then we'll move to the other topic. Yeah, that's my cover, clinical competencies and therapist psychology. So let's get that psychology out, and we create our own individuality, and then start liking our field and start learning and seek knowledge. Now, the other thing what I have observed in my bachelor degree, that we used to read MRI and CT scan, and here even when I see some of the practices, start taking that screen, that result MRI scan out and start seeing it. So what I learned in the US, that nobody actually knows how to read CT scan and MRI, and we are not even competent, or we are not knowledgeable to read MRI, and that's why we have reports to see the result of MRI and CT scan. So there was in college time. So if I don't read result right, then I feel like, oh, I don't know how to read MRI, I don't know how to read CT scan. But that's not my job. My job is how to read the correct biomechanics of this movement. My job is to look at the child and see that what I can do to make that child's life better. When I see any autistic symptoms, my job is to differentiate that symptoms and provide the best treatment to that condition. And the other topic, now I'm not in orthopedics anymore, but I think that this was an important thing to cover as well. So how much important it is to refer the patient for frequent MRI and CT scans, especially for the private practitioners who is doing orthopedic outpatient, or the adults who are treating, all the adults who are practicing orthopedic specialty. So let's know that one MRI causes 1 year of UV radiation, and which all are carcinogens. We know that. So there is a research by American Academy of Family Physicians that they have done. They are insisting don't do imaging for low back pain within first 6 weeks unless there are red flags include severe or progressive neurological deficits, bladder and bowel dysfunction, saddle paresthesia, sudden back pain with spinal tenderness, especially for if they have history of osteoporosis, cancer or steroid use or underlying conditions like cancer. So when patient comes to us, we just write down patient is not getting better in 4 or 5 days. They're coming every day and like for a week or so, and they're not getting better. We write down that patient may need MRI or CT scan. We send them back. It's lots of wasting of money of the patient time. Very inconvenient for patient as well. So and why I especially added this topic for the back pain, because back pain is the number 5th diagnosis that bothering all the countries. Um, so this is important that when we are, and even my pediatrics said that when I see lots of reports are being done, pediatrician to pediatrician, when they are going, they are doing the same reports every time. So this is also wasting of lots of money of patients and time, and this is also part of ethics, your morality. And the first rule of ethics is do not harm patient, and it also include the cost effectiveness of patients treatment and all the other investigation. Most patients will recover within several weeks of onset. So the back pain patient, they will get better in just within 5 weeks. They have the result if they don't have anything except I said that special history or the progressive neurological deficits. They will get better in 5 weeks. Majority of disc herniation with regress or reabsorb within 8 weeks of onset. In the absence of severe progressive neurological deficits or other red flags, there is strong evidences to avoid X-ray, CT scan, and MRIs. Studies have shown patients with no back pain also present anatomic abnormality on imaging. So do no harm plus patient's cost effectiveness is equal to ethics. Evidence-based practice. So I think we are now, India is enrolling, moving towards evidence-based practice, and which I feel very proud about. But still there are some cities, towns, some peripheral areas where we are still sticking to those same guidelines that we have studied in our bachelor degree, doing passive range of motion, doing passive stretching, doing same activities for like years, not changing anything, not looking into that passive stretching is not as effective versus the functional stretches. So this is the time now that at least read twice, 2 articles per day regarding based off your practice or based off your interest. Clinical practice guidelines systematically develop statements to assist practitioners and patients' decision about appropriate healthcare for specific conditions. So now if you Google, you will get different guidelines based on the diagnosis for neck pain, for back pain, for each and every, for rotator cuff tear, there are listed guidelines. So in US, what we used to have after in orthopedic settings, there is a fixed guideline we need to follow. After surgery, there is a fixed guideline for rotator cuff tear, for back surgery, for knee replacement. And it is similar to clinic, state to state. More or less some differences there, but it is almost protocol wise. It the weeks wise, duration wise, activities wise, it matched. So I think this is the time now where we also need to get into the CPGs to bring the uniformity of the treatment to get the maximum result for that conditions. Guidelines are designed to support the decision-making process in the patient care. Contents of guidelines are based on a systemic review of clinical evidence. the source for evidence-based practice, CPGs. CPGs benefits to patient, improve clinical outcome, reduce variability in clinical practices, increase transparency of evidence to justify interventions. CPG, how benefits to provider? CPG, quick access to synthesis of evidence, give clinician direct access to the knowledge base of the experts, self-assess their current practice and direction of the future clinical research. Now, if we practice both, just trust me, the psychology of being a therapist will change. It has changed a lot, but whatever it has remaining, we need to change that too. So if we start practicing CPG, the result will be better, patients satisfaction will be better, quality of care will be better, and then the cycle will be complete. Therapist will be happy, patient will be happy. That will spread more awareness, hopefully, and more satisfaction in the patient therapist in a bucket. So the other thing, evaluation. So what I have seen or I used to saw in the past, that here we every clinic has different evaluation format, assessment format, and some of the clinic has very thorough assessment. For us, for a pediatric therapist, we have to have a long, like we have to have a thorough assessment for our pediatric patients, which include subjective assessment, objective assessment, reflexes, range of motions, their fine motor, growth motor, cognitive, and then their gait, their milestone. So these are the basics. So pediatric therapist assessment is always thorough, I have noted. But in orthopedics or in other adults, I could be wrong. Again, I could be wrong because I have not seen many clinics here. But based on my past experience, we didn't have like enough. There are only 4 or 5 points, and that's it. So now this is the time where we should initiate a standard format of assessment across the states, like it was in US. We need to start doing here as well. Like this is ortho adults, neuro adults. Some of I have also, let me pull out. I have also pulled out APTA assessment format, which includes everything what it has to have in the assessment. And based on your specialty, you can define or you can design your own assessment. So these are the topics what it has to cover, from the history to systemic review. And as I said, that based on your specialty, you can always just pull out some of the important assessment tools and take out unnecessary. But there has to have thorough, just without initial time there was only subjective assessment. In the objective assessment, we used to do range of motion, MMT. We actually, I don't know how much we are taking subjective assessment by parents or by patients, but it has to have very thorough. And the goal part is most important. How we need to set up the goals. So assessment format, subjective assessment by parents or patient, plan of care, short-term goals, long-term goals, and patient's goals. Now, some of my therapists here, even I had to train them initially for a few months to how to set up, to just teach them how to set up the goals. For example, when I had, let's say I have a right hemiparetic cerebral palsy child, 3-year-old. So her goal, when I asked my therapist, what will be the goal for month of the June or 1 month for the July? And when they'll say that, okay, we'll increase strength in left upper extremity. But the strength, increase in the strength for that cerebral palsy child, it will just going to take years. It's not going to in a month. The child will not increase strength, and that is not the functional goal at all. Okay, it's the functional goal is what the child is not able to do and what he or she wants to do, or what he or she can do, or what how much we improve the functional mobility and the strength of the child. So the goal always have to be, hello. So goal always have to be functional and measurable. And when first time when patient comes to you always listen to their subjective assessment, because subjective assessment has lot to offer you, that where you can, from their subjective assessment, you can get differential diagnosis by yourself. You can get what patient's expectations are, what patient's goal are. Patients' goal are not, they don't want to improve their strength by 1 grade. They don't want to improve their range of motion by 15 degree. They don't want to improve their hip flexion or hip strength by 1 grade. They want to reach above head to pick up towel, to they want to wipe their back maybe. So you always want to ask patient what they want to do, and you want to write down that goal only, and in that month, if you reach that goal, you can show that to the patient that hey, you have reached that goal, and that will build a trust in yourself, that patient will trust you as well, and that's how patients start believing in our therapy. So that's what you want to write down. And you also want to talk to the patient. So goals must be functional and measurable. Improve core strength, improve leg strength. Since it's very vague, it does not mean, it does not hold any value. Child will be able to perform supine to sit independently, to sit independently. So that will be their functional goal. A patient will be able to, that child will be able to do some functional mobility that parents can see, that parent can notice that hey, this child is doing this, and they will come tell you that my child has started doing this and I'm happy, and now we need to move on to next goal. Because our therapy, PT is not like quick fix that you go to the pediatrician or you go to the ortho surgeon and they will give you, prescribe you medicine, and you take them and it's done. No, our course is long. Our course is long and it is hard. Even when I see myself as a patient, it is hard to be a patient for that long. So for that, to keep on, to keep the trust and to keep compliance in therapy, we have to give them slow by, like slow dose. Okay, that's our goal. We have reached this goal for 2 weeks. Now we'll move to the next goal for 2 weeks. We will reach, and then they will, by reaching the goal slowly, they will start putting trust in you, and they will stay with you for a long time. So it's another key. One more thing to adding the assessment part is outcome measures. So I'm sure now master students and MPTs, and they've been using all the assessment scales. But I still thought it's a good idea to just draw a point that try to use as many objective assessment as you can. Again, we ourselves, we have like, we are more, when it's easier for us to look at the number and compare and then convince ourselves than somebody else is telling us. Okay, if my doctor is saying something and then he's showing me that hey, it was 30, your oscillatory scale was this 30, but it has got better to 8. So your pain is improving and your functional mobility is improving and you are doing good. So it's again, it's very important to show the patient the objective scales different or how much improvement they have made, and they always get convinced by seeing the numbers at how much better I have got. It's just patient psychology, and I think for everybody. If I was a patient, I would feel the same way. Outcome measures. Measuring outcomes, it's a critical component of physical therapy practice. Outcome measures is the result of a test that is used to objectively determine the baseline function of the patient at the beginning of the treatment. Outcome measures are important in direct management of individual patient care and for the opportunity they provide the possession in the collectively comparing care and determining effectiveness. With the move towards evidence-based practice, objective measures of outcome are important to provide credible and reliable justification for treatment. And I'm surely many of the therapists, many across India, we have and just keep on doing so more and more. Now the documentation part. Very little documentation in our field, in our country, than in the States. Now again, many of you know that why it is important in USA, because documentation was must to get reimbursement through insurance, right? So that's why we had to do more documentation. So we don't have to do, like, I'm not saying to get. So when in USA, when I finished my patients around 5 o'clock, I just go home and finish my household course, and then from 8 o'clock to 10 o'clock, I had to finish my documentation. So every day, 2 to 3 hours, I spared my time to do documentation apart from my work. So that's documentation I had to do. Now that is not, we don't have to do as much, but there is still, we need to do optimum documentation for our safety, for patient safety, for to bring out the uniformity in the practice across the states, across India. So very, as I said, we need to improve in our country. It's very little. Patient's written consent. Now what I have seen here is anybody can video or photograph to any patient. And they can share everywhere, and I don't think that is right, no matter which country you are in. Okay, they are patient, and we should respect their privacy. Now, if I'm in Junagadh is a district. It's not a city, like it's not Ahmedabad or Rajkot. Still, majority of, we have made that written consent of, if your child, if it's okay if we take a picture or video just for the research purpose, then only they have concern, and or for the website, then only they have, so many of the parents have said that we have not shared our child's condition in our society, in our families, and we don't want to, and like their immediate family, and we don't want to share my child or anybody's picture on the social media. And I completely respect that, and I think we all should respect that. Just if you want to do it for whatever the purpose is, just have them in written, take their consent. Just don't do it just because you are a doctor and they are patient. You are not liable to take their pictures without their consent. So that's important thing I will say, that don't just do it. Physiotherapy documentation is an important legal and professional requirement. WCPT recommends that accurate PT documentation should include personal data, consent, examination, evaluation, diagnosis, prognosis, plan of care, intervention. I'll just take some water break. Intervention, treatment, re-examination goals, parents' expectation or patient's expectation, discharge outcome, and discharge summary. So this is the article which provides a conclusion that PT documentation accuracy needs to be improved in order to promote optimal continuity of care, improve efficiency, quality of care, and recognize patients' need and adverse effect. Due to poor documentation, it was not possible to establish a relationship between the accuracy of physiotherapy about the diagnosis, intervention, progress, and the outcome evaluation. So, as I said earlier, that our course is longer. We we need proper documentation so we can compare, because patient's memory is very short. My memory is very short too, that I don't remember what was the patient's presentation a week ago, or how much they have got better. And even patient forget their condition, that how much over the month of treatment, how they got better. So if we have properly documented, if we have properly reassessed, we can compare and we can tell them, like, if this is where you were and this is now you are at. So see how much improvement you have made. And that's a small difference. Small prognosis can make a big difference in their psychological status. Electrotherapy. So I have seen somewhere, and I hope it's just a few clinics or just a few areas where I have seen this, but we also need to take that. We need to cancel this. We need to take this mentality out from therapist mind, from like this is not right to charge fees or charges based on the modalities. So I have seen, like, if you have taken short SWT, short wave diathermy, then you will be charged 50 rupees. If you have taken IFT, then you will be charged for 70 rupees. That's completely wrong. That's completely non-ethical. We are teaching those patients that we as a therapist are less important, our hands are less important than the modalities. The modalities are more important. So in a way, I have found that somewhere we are responsible for making those patients believe that electrotherapy is more effective. Taking shake are more effective than doing exercises. I know the patient, maybe they are illiterate, they don't have enough education, awareness. I also know that we are lacking, they don't even have that much of PT awareness. Yeah. But somewhere I see myself responsible for doing that too, that in some of the practices, we have like 4 or 5 patients at a time. And then we put one patient on short SWD or IFT, and then we start treating that other patient for 10-15 minutes, and then we jump back to that, and this way we are not going anywhere. And this way we are imposing that mentality, because when we want to put that patient into the IFT while I'm treating the other back pain patient, I'm teaching them, okay, chalo, let's take the IFT that will first finish that will help you in the pain relief, and we don't teach them that what are the effects of that IFT and how long, what does it do. We just impose that, okay, this will make you feel better, and then they will start learning. And that's how we are creating a whole cycle of making that patient dependent on electrotherapy. Again, that is my belief, that is what I have seen and experienced, and I hope I'm wrong. But if that is the thing, then we need to fix this problem. Okay? Patient become dependent on modalities because of us. Provider, because of lack of their knowledge and lack of providing them education about the proper use, duration, effectiveness of electrotherapy, that electrotherapy is not going to fix their pain. Ultrasound has less than 2% of effectiveness on any conditions, and not so, moreover, it's just a placebo. Then we are still keep doing the ultrasound and telling patient that it's getting better. So start from us that fixing the electrotherapy is effective. I'm not saying that we need to completely forget that it's very effective, but we need to give them proper knowledge, proper what are the duration, for how long we need to use it, not making patient dependent on the electrotherapy. Pain relief, re-education of muscle by using targeted muscle stimulation. It's improve the circulation and flow. It also helps, as I said, re-education of some of the muscle. Functional electrical stimulation is also effective in so many of the hemiplegic, hemiparesis, paretic cerebral palsy children. and adults. So it is effective, but give them proper knowledge of for how long they need to use it. And some of the like mechanical back pain or shoulder pain where we are using shortwave diathermy, just teach them it is a short period pain relief. If it gives you pain relief, then you can do the proper exercises, and then proper exercises will make you feel better. Our hands are, our mind, or we are as a therapist are way more important than that modalities. One more important part, patient education and home plan. Benefits of patient education: so improve adherence to exercises, diet, and medication. So in my clinic, what is my all the therapists has their own schedule, and I think all the pediatric settings has the same format, that every patient is taking 45 to 50 minutes for their therapy. Now pediatric setup is different, but what I have seen in what I have done in United States, that every therapist in adult or in ortho therapist was getting 45 minutes for that particular patient and 60 minutes for the assessment. Okay. So for 45 minutes, we know that this patient is going to be with me for 45 minutes. So I have enough time to give proper education to that patient, because then I will get whatever the exercises in half an hour while I'm providing the activities I am teaching them to. In here, maybe because we don't give in adult setting, we don't give like continuous 45 to 50 minutes to a patient here. We sometimes therapists have to swap to other patient to patient, and they also have we have aid in between. So I feel taking we are taking less time to provide the patient education, and that not providing proper education is also we are getting less outcome at the end of the treatment. So if we can if we can structurize our schedule with the patient, and if we can get more time with hands-on, and then we can at the same time we can provide patient education, enough time for the patient education that can help you the better outcome. So the benefits here: improve adherence to the exercise, diet, and medication, realistic patient expectation, especially regarding the timelines, because we know that hemiplegic patient is not going to get better in a month or 15 days. They will going to take time. So it is important to give them realistic approaches towards life and outcomes, easing of fear and apprehension, increased satisfaction with the treatment plan leading to the more referrals. So with the treatment plans leading to the more referrals means when majority of our referrals are coming out from our doctors. And one more thing I also wanted to add here, that few of my therapists said that, ma'am, please add PT awareness. We don't have many of the, not sure in the big cities, but in Saurashtra here, we don't have as much of physical therapy awareness in patient population. And I also believe that majority of 90% of the therapist patient we as a therapist must provide proper like CMEs or proper doctor therapist time, that way we can go and talk to them with the personal all the, like I am in contact with all the pediatrician here, and just with the time they get to know that what are the conditions we are treating. Not many pediatricians around here they were familiar with the autism spectrum disorder at all, but it's been a year, and I think it has made a lot of difference in the pediatricians approach as well. So first start with the doctors, or start with the people whom we are getting most of the referrals. That's the way we can increase the therapy awareness, along with the other efforts we can do to increase therapy PT awareness. So I'll come back to the benefits of patient education. Increase satisfaction with the treatment plan leading to more referrals. It's 4:48 already. And just have 10 more minutes. Increase satisfaction with the treatment plans, leading to more referrals, and open environment to discuss questions and concerns, improved outcome in the patient's health and well-being. So these are the benefits of patient education. Evidence-based practice is very important to provide proper education to patients. This was the most important topic I covered in Bhutan when I was teaching them back pain. And I don't know in India how much orthopedic surgeon or the physician or even a PT recommend bed rest. But based on the research, bed rest more than 2 is not advisable. So these are some studies. First one is doing by Harvard, and the second one is PubMed, I think. So researchers from University of Washington surveyed several thousand of physicians about back pain management. Most believed in the utility of prolonged bed rest along with the muscle relaxation and narcotics. Strong evidence support prolonged bed rest does not improve outcome. It just increases the disability, depression in the patient, lack of mobility. Bed rest cannot help. Is there a benefit of active physical therapy exercises? 14 out of 18 control studies do report that active exercise can improve outcome and may result in fewer episodes of back pain in the future. TENS, ultrasound, massage, or corset means the belt used to treat back pain. So randomized control trials suggest modalities provided under the intensive care of the provider resulted in the greatest satisfaction, but there were no significant difference in the objective outcome measures. So even the electrotherapy did not make much difference. It increased satisfaction because therapist was providing the treatment. So they had the belief that the therapists are doing the job right. So I'm getting better. So although some patients may need to temporarily modify their activities, so if the patient is in acute care, you don't want them to do any heavy activities. So of course, you want to start with the very light exercises or activities. During the acute phase of back pain, most should be encouraged to avoid bed rest and resume normal activities as soon as possible. Now, again, just remember, being a therapist, when patients come to us, their goal is they were not able to do something and they want to start doing that thing again. When parents come to me, they ask me that my child is not sitting, my child is not holding anything, and my child is not crawling or standing. He's 2-year-old. They don't care about the strength, range of motion. All they want is to get that functional milestone. What they care is to get that functional mobility in the child. The same thing applies to everybody. So resume normal activities. So start with low activities and then resume. So our approach should be how to improve their functional mobility rather than improving the range, strength. For those so motivated and active exercises, physical therapy program appear to improve outcome and speedy recovery. Now again, this is something important. Taking any type of malpractice. Lots of malpractices we have been seeing, and it's everywhere. But I think I need to address it so we all can just do little. We can take initiative to improve and advance our rules, ethics, and clinical guidelines. Taking any type of financial or moral advantage of patients' lack of awareness or illiteracy. Malpractice is a type of negligence. It's a failure to provide degree of care required of a professional under the standards and scope of practice guideline, resulting in harm. Lots and lots of cases of malpractices, especially in the private practices. I have also seen that some of the therapists writing a prescription. Now, again, looking at our scope of practice, we should not do it. This is not something we have studied. This is not something we are liable to do it. Providing unnecessary electrotherapy, like some of the clinics, they will give intensity in the tens or years so high that the child or the patient will have the burn. I think I have seen that in the past, and that's complete malpractice. You are damaging that patient, you are harming that patient, and that's completely non-ethical. So we must be careful on that part. Asking patient to continue treatment with no improvement in the result. Asking patient to continue when there is no need or when there is not many of the frequencies required. That they probably don't need to come every day. If you treat them once every other day, 3 times or 4 times a week, they will get the same benefit. And still you are treating that patient every day. Now that patient doesn't know, but you know what you are doing right or wrong. Risk control recommendation for treating a physical therapist. Provide clinical support and supervision for PTS, aides, and students in compliance with the standards of practice for physical therapy. Recognize patients' medical conditions, comorbidities, and any additional risk factor that may affect therapy. So you need to be alert while you are treating. Never leave the therapy area when a patient is receiving services from another level of staff, like student or some of the rehab aid. If they are doing any of the active movement, active exercises, you need to stay present. Never leave the therapy area. Okay, covered that. Closely observe high risk patients. Closely observe the high risk patient to prevent falls and never leaving them unattended. Risk control recommendation for a PT practice owner. Knowing the current scope of practice. This is for the owner of the practice. Knowing the current scope of practice, parameter of PT, PTA, rehab aid, and students. Ensure that clinical practice comply with the standard that are endorsed by a professional association, State Practice Act. Now we have GSCPT, which we are very grateful and thankful for, and facility protocols. Be knowledgeable of the levels of supervisory responsibility of a patient, of a physical therapist. Know when it's acceptable for a PT to have general, direct personal supervision of PT students, intern, and rehab aid. They just don't leave them unattended. Okay, they will be fine. No, you are liable. This is your clinic. You are liable to take care of your patients. These are my references, and I thank you very much. Okay, guys, we can start any questions if we have.
Thank you, ma'am, for the information and knowledge sharing. Uh, till now, we don't have any questions. Still, I request participants if they have questions, they can just drop in the chat box. I would like to request Uttara ma'am for the further procedure. Before that, I am really very thankful to the IIP technical team as well as IIPWC and IIP India and my today's resource person, Dr. Varsha ma'am, for the kind knowledge for us. Thank you, ma'am.
Thank you.
Thank you, Dr. Varsha, for sharing your insights and knowledge. And thanks to Dr. Krupa for moderating the session and also IIPWC Gujarat team. I would also like to thank Dr. Sanjeev Jha, IIP President, and Dr. Ruchi Vashni, Treasurer, for providing this platform for conducting webinars for all physiotherapists. And I also thank my rest of the technical team for helping out with the arrangements. Thank you.
So are we good to go?
Yes.
Okay, thank you
Yes.
again.